Okay. So let's stop. Okay. Hi everyone. How's everyone doing? I'm good. We good. Great to see everyone. I'm Jonathan again. I'm one of the fellows from UC Davis. Sorry for running a little late today. We got a little stuck in traffic, but today we're going to be talking about thyroid emergencies. So as you know, there are a lot of different kind of emergencies here. This is kind of a really quick overview first. This slide right here about the thyroid sequence, right? So when we start with the thyroid here, we start over here with the hypothalamus. The hypothalamus releases thyroid TRH, thyroid regulating thyrotropin releasing hormone, which then stimulates the anterior pituitary to release TSH. After TSH is released, it triggers the release of T4 and T3 from the thyroid gland. And about 80% of circulating hormone is T4. So T4 is then converted to T3 at the target cells, kind of in your tissue and everything like that. And both T4 and T3 provide negative feedback to the hypothalamus and pituitary, which means if you have a lot of T4 and a lot of T3 floating in your body, it will go back and tell the anterior pituitary and the thyroid gland that you don't need that much thyroid to be released anymore. So hyperthyroidism, this is basically it's a very broad condition. And what happens is when the thyroid gland produces an inappropriately high amount of thyroid hormone. So there's way too much thyroid hormone being produced here. If we draw labs on these patients, it will show a low TSH, an elevated free T4, and an elevated free T3. So we go back to this slide right here. So the TSH will be low and the T4 and T3 will be very high. That's how we know we have a high thyroid level. There will, if you sometimes patients who are hyperthyroid, they are asymptomatic, but sometimes they can be symptomatic as well. And when we have any kind of overt hyperthyroidism or a lot of symptoms that are going on, that will basically be something like Graves' disease or toxic multinodular goiter or thyroid adenomas. All of these conditions can cause overt hyperthyroidism or basically having symptoms from your hyperthyroid. Subclinical hyperthyroidism sometimes is you're not able to feel any kind of symptoms. You just have high lab values. Maybe your heart rate's a little bit high. And conditions such as thyroiditis, those can all lead to subclinical hyperthyroidism. So thyrotoxicosis here, this is basically a spectrum of illness from elevated thyroid hormones. So it can range from very mild symptoms such as a fast heart rate to something like thyroid storm. The presentation includes palpitations, edema, goiter, exophthalmos, tachycardia, tremors, and weight loss. So those are all symptoms that can happen when you have an elevated thyroid level. So thyroid storm, this is the kind of the most extreme end of what can happen when a patient comes in with high thyroid levels. So for example, so the mortality rate for thyroid storm is very, very high. It's about 10 to 30%. And this is the most extreme cause or condition of hyperthyroidism. It can be, sometimes some patients can, they're hyperthyroid, they're not taking their medications, and it becomes very, very elevated. But it can also come from a lot of different things, such as from trauma, from infection, from, some kind of medications, from things like DKA that we talked about, last time, from psych conditions, from CVA, like a stroke, from like different kinds of cardiac or pulmonary issues such as a pulmonary embolism, an MI, a CHF exacerbation. The number one cause of thyroid storm is usually an infection. So a lot of times when patients come in, you're concerned about thyroid storm, they're tachycardic, they're febrile. The other thing we worry a lot about is sepsis. So we usually draw blood cultures and check the lactic level as well. The presentation of thyroid storm here, it can come with very high fever, greater than 40 degrees Celsius. Patients are usually diaphoretic. They can be tachycardic up to atrial fibrillation or into ventricular fibrillation. You can have something called high output cardiac heart failure, where your heart it has good ejection fraction, but it's not pumping as well. Pulmonary edema, hypertension, and pretibial edema. They can sometimes come in as altered mental status, or feeling confused or delirious. They're sometimes psychotic. They can have tremor or restlessness, lead lag or proptosis. You can sometimes feel a thyroid nodule or goiter on their throat right here. And they can sometimes have abdominal pain, jaundice, or hepatic failure as well. So thyroid storm is something you should, a lot of times you want to make sure you consider this in your differential when we're taking care of patients. It's a condition that's very easy to miss. They can sometimes they sometimes usually have a history of hyperthyroidism and can present with kind of an acute illness or deterioration. Sometimes you want to consider that they have new onset atrial fibrillation or dilated cardiomyopathy. If they have new delirium or psychosis with tachycardia and fever, in a septic appearing patient without any source of infection, you also want to consider thyroid storm. So the workup here, the labs are pretty similar with most other type of hypothyroid patients. It really is a clinical diagnosis, but these labs can be helpful sometimes. You want to check, basic labs, LFTs, MEG, and FOS. We always want to check a TSH and a free T3 and T4 to kind of see, are their hormone levels high? Are they low? Are they normal? Is this something we need to be concerned about? You can check a CPK for, if concerned about rhabdo, or coags, for possible DIC. And again, a lot of these patients can present very similar to sepsis or have a co-infection with sepsis as well, with their high fever, their tachycardia. So we oftentimes draw lactic and blood cultures as well. This is called the Birch Wartowski score for thyroid storm. It's in 1993. Because again, thyroid storm is not a very common condition. And because of that, this score is not really externally validated. We haven't done a lot of research to kind of see what's going on there. But this is a score you can sometimes use to help, determine if you're, how concerned are you for thyroid storm. But again, there are many other conditions such as sepsis that will score very high on this as well. So just because the score is high doesn't necessarily mean someone has thyroid storm. It's just is a useful tool to help with everything. But again, since it's not a very common condition, this score hasn't been studied a lot, and we don't know very well how well it works. The management for thyroid storm, the first thing is we want to make sure we manage their airway. So we know in patients who are altered or confused, we want to make sure that they're able to breathe on their own, and they're protecting their airway. If they are agitated, we want to give them benzos, like benzodiazepine. Like you can do Versed, you can do Ativan to help with their symptoms. You can do external cooling, putting them on cool blankets, using an external fan to try to cool them down. And you can give them fluid resuscitation. You can give them plenty of fluids to kind of help with their hemodynamic stability as well. Beta blockers are the first line that are the kind of first medications that we give. And so the most common one that you can use is propranolol. You can do about 0.5 to 1 milligram IV, followed by 1 to 3 milligrams every 10 minutes, and then followed by a PO dosing of that. And the reason why propranolol is useful is it basically decreases the peripheral conversion of T4 to T3. Remember when we look at the initial slide, your external tissue is converting T4 to T3, and that is the active thyroid hormone here. And so beta blockers will prevent that, it will at least decrease that conversion and help with the condition. Propranolol is also non-cardioselective, so it will help with tremors and agitation as well. You can also do esmolol, about 250 to 500 micrograms per kilo IV. This has a pretty short half-life. This is kind of what we use for aortic dissection as well. And so you can titrate it. So in case you're not sure about how someone's heart, their heart failure or their heart condition, you're able to use esmolol to kind of see how they handle it. And if they don't do well, you can stop it pretty quickly. So that esmolol is nice if you're unsure about how someone's heart is working. You can also do a tenolol, 50 to 200 milligrams every day. If they're, kind of, if they've improved from the propranolol, you can try that to make them feel a bit better. This is cardio selective. Um, and another option is, for example, you can do risperidine. And risperidine kind of blocks the uptake of serotonin, norepinephrine, and dopamine into the presynaptic storage vesicles. And by doing that, so if a patient has a contraindication to beta blockers, like if they're in shock, if they're in cardiogenic pulmonary edema, and you can't give them a beta blocker, you want to give them risperidine. You can get 1 milligram IM followed by 2.5 to 5 milligrams IM every 4 to 6 hours. The next step in treating patients with thyroid storm is thionamides. And so there's two options we can choose from here. There's methimazole and propylthiouracil. And again, both of these decrease the synthesis of T3 and T4. So remember earlier when we were talking, so the beta blockers basically prevent T4 from being converted to T3. But the methimazole and PTU here, it basically it decreases T3 and T4 from being created at all. So PTU, you can give about 600 to 1,000 milligrams by mouth, followed by 200 to 400 by mouth every 6 to 8 hours. And one of the black box concerns here is hepatotoxicity. So you want to make sure you check liver enzymes before you start them on this medication. PTU, if a patient is pregnant, this is the preferred medication because it's thought to not cross the placenta as much compared to methimazole. Methimazole is about 20 to 25 milligrams by mouth every 4 to 6 hours. And the benefit of that is that it can has a longer half-life. Both of these medications can cause agranulocytosis. So we want to be careful, like when we're giving these medications that we also get a baseline CBC as well. So before we start these medications, we want a CBC, a CMP, and LFTs kind of establish the baseline. That way, if we're concerned about something and we see a change later on, we can say, what were they like before we started them on this medication? The next medication we can do is iodines. And what iodines does is it blocks the release of pre-stored thyroid hormone. So it goes even farther up the algorithm and the chain there and prevents thyroid hormone from even being released. The Wolff-Chaikoff effect is basically what happens when high doses of iodide inhibits the T3 and T4 synthesis and release. You want to give this medication at least 1 hour before the thiamide, this medication that we just talked about right here. Otherwise, it can increase the T3, T4 synthesis. So it's a little bit of a paradoxical type of effect. There are many different options here. You can use glucose solution, 0.4 milliliters by mouth every 6 hours. You can use a saturated solution of potassium iodide, 0.25 milliliters by mouth every 6 hours. And if you're concerned about amiodarone, like if a patient's taking amiodarone, you're concerned about amiodarone-induced thyrotoxicosis, you can do lithium, 300 milligrams every 6 to 8 hours. And amiodarone is about 37% iodine by weight. And what lithium does is it inhibits the thyroid iodine uptake there. The next step here is steroids. So thyroid storm can cause depression at the hypothalamic pituitary axis. So what we talked about earlier, the axis we were looking at. And so it can cause, so when you cause depression there, it can lead to adrenal insufficiency, like not having enough hormones being made. Hydrocortisone, you can do 300 milligrams by IV, followed by 100 milligrams every 8 hours, or you can do Decadron IV every 6 hours to make sure that the patients don't go into adrenal insufficiency. And steroids also inhibit the peripheral conversion of T4 to T3. Some other treatments for thyroid storm, these are not as used as often compared to the ones earlier. But things like cholestyramine, you can do 4 grams by mouth 4 times a day, which decreases the absorption of thyroid hormone to the GI system. You can do plasmapheresis. And you can do antithrombotic therapy for if someone's in atrial fibrillation. Any questions so far on hyperthyroid or thyroid storm before we move on to the other end of the spectrum here?
Do you suffer any patient before you have a hyperthyroid in your department?
Say one more time.
Did you treat somebody with the hyperthyroidism?
We definitely treat with hyperthyroidism, not so much the oh, you're saying do we sedate? Is that it?
No, in UCDB, we have not a lot.
We see a lot of hyperthyroidism, but not thyroid storm.
Really?
Thyroid storm is very rare. Like we haven't seen a lot of cases of that. Do you see a lot of them here?
We have some cases here, and really? we know that we have plasma penetrants for the severe cases, and they work.
Oh,
some guidelines they don't say that it's workable, but we work here for 2 or 3 cases.
Interesting.
And they just the ICU doctor showed to so that this is workable, but sometimes when you have a severe storm, the patient go with the severe condition. They intubated, the ventilation, and after do it all and like iodine, something like what you say, and the plasma paralysis is the last change for them.
Yeah.
After that, but some people say that this is the timeline for thyroid. It's not if you work or not, the people will get better. So it's just like we talk more about that.
Yeah. Exactly. So so a lot of times, we start with some of the medications, like up here first, the beta blockers, PT or methimazole, iodines, and then if these are not working, like you were saying, like plasmapheresis is one of the options as well.
Here we often use the medicine for pre-operation. So if people have some the history of disease, they have thyroid. So when the patient comes to operation, usually the endocrine doctor will give them iodine and something like to preventing the thyroid storm.
Yeah, definitely. That's an option to have medicine as well. Right. Anyone else have like interesting cases about thyroid storm that you've seen before in the past?
Usually you
I got very so in the lymph scan, you have severe thyroid storm symptom. That's like high fever and abdominal pain.
Yeah.
And so we have patient with pressure in their abdomen.
Yeah.
So see, they only got abdominal pain, fever, and how can we distinguish from thyroid storm and severe infection? That's because we in the first hour in session we have the flow chart to infusion to get the antibiotic for the patient. And first in the thyroid storm, we only use the infusion. How can we distinguish and we got the first treatment for the patient. So,
interesting. So it is, as you said, it's very hard to distinguish sometimes between infection. Sometimes the white blood cell count can help a little bit, but a lot of times they're also tachycardic, they have a fever. The lactic can be high and usually an infection, but sometimes in thyroid storm as well. And sometimes it's both. When I say both an infection and they have thyroid storm going on, it can be both as well. Anyone else? Anything? Other interesting cases or questions before we move on to the next section?
In Cho Ray, they say that if you think of that, you can treat it, no matter what. If they have not. That means if you are thinking about thyroid storm, just give the medication.
Yeah.
No matter what, if they have not.
That's true.
That's true.
Because it doesn't have you're saying it doesn't have an effect on it.
So people here in Vietnam, they don't go frequently to the clinic to have a test. Yeah. So sometimes they say that they have a thyroid disease. They don't know exactly what the thyroid one.
Right.
Something like that. They have I have a disease under my thyroid. Something like that. So if you heard that, they go to infection, you must treat this just like thyroid storm. That's we are learning to do that. It's the same in you, right?
So it depends, right? Because like I said, for example, especially the beta blockers, right? If we're treating thyroid storm, we're going to give them beta blockers as the first line. But the concern is we don't want to give beta blockers to patients who don't need beta blockers, right? Because it can cause a lot of problems. If they have asthma, if they have COPD, if they have heart failure, we don't want to just give them a beta blocker. So it's kind of a balance there. So, some conditions you can definitely kind of treat no matter what. But this one we want to be careful because patients may or may not actually have, if they're not in thyroid storm and we give them beta blockers, it can cause other problems as well. It can cause heart problems, it can cause lung problems, it can cause breathing problems as well. And even for steroids, right? Like if a patient doesn't need steroids, you don't necessarily want to give them like prednisone is not too bad if you give it by mouth, but like IV, IV hydrocortisone is very strong. So sometimes you want to kind of balance the two and see if they actually need if they actually need steroids, if they need treatment for thyroid storm. Any other questions or anything else anyone wants to add for now?
Show me about the indication for thyroiditis in the thyroid storm.
You in the case usually what we do is the first line we would do all these medications first, the beta blockers, the PTU, the iodines, and the steroids. And if so again, it's different in every hospital. For us, if it doesn't work, that's when we kind of consider starting to do plasmapheresis. And plasmapheresis is not always easy to get. But in places, maybe if you're working in a hospital that does not have some of these medications, like maybe you have beta blockers, but you don't have the rest of these, and the patient seems like they're getting worse or they're decompensating, that may be a reason to go for plasmapheresis.
In Jordan, before we got plasmapheresis and CRT. Sometimes I see doctor get CRT for later.
Yeah.
We thyroid storm. But we recently junior plasmapheresis. We have two types. One for the nephrology department. It can use last plasmapheresis.
Yeah.
And we also can use the CRT same to plasmapheresis for patient.
Yeah.
So this is the reason why I asked you.
Yeah, it depends on it depends on every hospital, and like depends on who the endocrinologist and nephrologist is as well, because they all have kind of different ways of approaching it. Some things here. We'll go through hypothyroidism, and we can also talk, and we'll have more time for questions kind of afterwards as well. So hypothyroidism, this is kind of the opposite of hyperthyroidism, right? There's many different forms of hypothyroidism. This includes the primary form, which is failure of the thyroid itself. So the thyroid itself is failing. What you see is an elevated TSH level because the body is saying, my thyroid, I don't have enough thyroid, I need more. So it's releasing the thyroid stimulating hormone. The thyroid itself is still not working. So you'll see a low free T4. Some of the causes of this include autoimmune disease, thyroiditis, if a patient has had an ablation before, radiation to the neck, infection, it could be congenital, it could be medication related. You can also have secondary hypothyroidism, which is when you have low TSH and low free T4. So the pituitary, which is above the thyroid, is not working. So it's not even able to release any thyroid stimulating hormone. This can happen when you have panhypopituitarism, pituitary adenoma, tumors, or infection. And the symptoms of hypothyroidism is kind of the opposite of hyperthyroidism, right? You have weakness, you have lethargy, you have bradycardia, you get pericardial or pleural effusions, you get edema and hypothermia. And the general treatment for hypothyroidism is to give levothyroxine or Synthroid, about 25 micrograms every day. So if a patient is just hypothyroid without any other symptoms, then we can give them levothyroxine. So myxedema coma is on the far end of hypothyroidism, right? So this is the new term that we're using now is called like decompensated hypothyroidism. Because we often see a lot of patients who are hypothyroid, but when they go kind of way on the far end of the spectrum, that's when you get something like myxedema coma, when they become very decompensated. So this is defined as hypothyroidism causing organ failure. It has a very high mortality rate, about 30 to 60%. And the precipitating factors here include heart failure, stroke, a GI bleed, either cold exposure, hypothermia, medications, a heart attack, sepsis, or trauma. So again, there are a lot of different conditions that can kind of trigger a myxedema coma. The workup of this is pretty similar to kind of the hyperthyroidism here. We want to get basic labs. We want to get thyroid studies, the CPK and EKG. And again, so we want to figure out, there's a lot of different precipitating events, right? Like CHF, stroke, GI bleed. We want to make sure that we're working up those conditions as well, in addition to working out why they have myxedema. The management of myxedema coma includes, management of the airway in case they're not breathing. You can give them normal saline, if they're very hyponatremic. If they're hypoglycemic, give IV dextrose. And you want to rewarm them. So just like we were trying to cool the patients in thyroid storm, we want to warm the patients who are in myxedema coma. We can give steroids for patients with myxedema coma. And so the starting is usually hydrocortisone, 100 milligrams IV. And basically you want to do this before repletion of the thyroid hormones to prevent an adrenal crisis. And the way this works is T4 that we're giving them will basically enhance the clearance of cortisol, which can exacerbate the underlying adrenal insufficiency. So normally there's about 1,000 micrograms of T4 circulating in the body. So before we do that, before we replete, we want to give them steroids to make sure we keep their adrenal system supported before we give them steroids, before we give them T4. So T4 levothyroxine is about 200 to 400 micrograms in an IV bolus, followed by 100 micrograms every day. And so you can give T4 empirically because this is the inactive form of the thyroid hormone. Remember, it needs to be converted to T3. If you want to give T3, which is 5 to 20 micrograms IV bolus, followed by 2.5 to 10 micrograms IV every 8 hours, this is the active form of thyroid hormone. And you run the risk of arrhythmias here. So you want to wait for labs because T3 is an active form. So T4 is okay just to give it because it is an inactive form. But T3 is an active form. And that's why we usually want to wait for labs and EKG to make sure we don't, kind of precipitate an arrhythmia that's going on. The last one we're going to talk about is the adrenal glands. So the adrenal glands, there are a couple different parts, right? There's the outer cortex, and the outer cortex of the adrenal glands, which kind of sit right above the kidneys. It makes the mineralocorticoids such as aldosterone, which retains water and sodium and excretes potassium. And also makes glucocorticoids, including such as cortisol, which increases blood glucose, decreases the immune function, and increases stress response. And it also produces androgens. The intermedullary zone of the adrenal glands focuses on the catecholamine. So this is where dopamine, norepinephrine, and epinephrine are produced. Here's another example of how the adrenal glands work, right? So first we have the hypothalamus, and when stress stimulates the hypothalamus, it releases CRH, which stimulates the pituitary gland to release ACTH. So ACTH goes to the adrenal glands, and it stimulates production of aldosterone and cortisone. And this can lead to, and aldosterone, again, it promotes sodium reabsorption, potassium excretion, and water reabsorption. And in cortisol, it can support the immune system function and metabolism as well. Adrenal insufficiency, again, there's many different types of this condition. So the primary adrenal insufficiency is when you have a decrease in cortisol and aldosterone. And causes of this include, it can be autoimmune, you can get adrenal hemorrhage, it can come from infection or medications or sarcoidosis or metastases from a cancer. A secondary adrenal insufficiency leads to decrease in ACTH, which is leading to a decrease in cortisol production. And this is a disruption of steroid therapy from pituitary disease or sometimes from head trauma. And tertiary adrenal insufficiency is basically when all the way up the chain, when you have a decrease in corticotropin releasing hormone, which leads to a decrease in ACTH. And this is most often caused by a cessation of steroid therapy. Adrenal insufficiency. These conditions are very hard to detect. So the labs you want to draw here include a CBC for eosinophilia. You can get a BMP. You can try to get a random cortisol level, but sometimes that doesn't always, point to adrenal insufficiency, especially if in that moment their adrenal glands are working okay. And in an ACTH stimulation test is sometimes really done outpatient. We rarely do that in the emergency room. So there's two, again, there's primary adrenal insufficiency. You'll often see high potassium, low sodium, and low chloride. The BUN can be high or normal, and the glucose can be normal or low. In secondary or tertiary adrenal insufficiency, you can see normal or low potassium, high or low sodium, usually normal chloride, normal BUN, and a low glucose.
So is it 1 degree or 2 degree, 3 degree, right? Is it the degree?
Yeah, correct. First degree for like primary would be the one right there in the middle, and then secondary and tertiary is the one on the right side.
So why do you do it?
Why do we do what?
Like 1 degree, 2nd degree, 3rd degree for what?
No. It's primary, secondary, and tertiary.
All right.
Oh, sorry, that was a little confusing. So we're the three kinds of adrenal insufficiency: primary, secondary, and tertiary. This is basically like primary is what it would look like right here. Let me see if I can find the pen here. Like primary would be like right here,
primary.
And then secondary and tertiary. These are the typical labs that usually are shown, but again, it sometimes can be a little bit different. Typically, the labs would show something like this. Okay. Adrenal crisis. So again, this is the farthest end of the spectrum of adrenal insufficiency that can happen. And so what happens here is, again, stress usually causes adrenal crisis. Infection, surgery, trauma, exercise, can be emotional, fever, GI upset, or GI symptoms. What you see is severe hypotension and vasodilation and shock, which is not responsive to IV fluids and vasopressors. So, let's say you give them their full, 30 cc's per kilogram of fluid for sepsis, and they're still very hypotensive, and you give them, you start them on norepinephrine with a central line, and they're still very hypotensive. You want to consider whether or not they're in adrenal crisis. The presentation here can be nausea, vomiting, abdominal pain, weakness, confusion, and fever. And the treatment for this is you give hydrocortisone 100 milligrams IV bolus, followed by 25 milligrams every 6 hours. And you should definitely consider adrenal crisis in most cases of septic shock. So at least when I worked in the ICU in residency, we, after about 1 day, if the patient was not improving with fluids and with vasopressors, we started them on hydrocortisone 100 milligrams IV about every 8 hours or so to see if that would improve. So if a patient didn't get better from the fluids and from the vasopressors, we automatically started them on that. That is all we have for the lecture part. Does anyone have any questions or interesting cases that we want to talk about?
Yeah, I got the question. So the dose of chemical control in that is so that you in the AI that you on the algorithm grab products. And after that, we use 1 gram for every kilo of patient.
Oh, interesting.
Yeah,
interesting. Thank you.
It's higher than your
higher than that. Yeah, it's very which is why I think this is very interesting, because every hospital does things a little bit differently. But yeah, that's definitely a very interesting, that's definitely a very good way to do it as well.